Okay, I'll move to the case. Okay. Case presentation. A 60-year-old medical school physiology professor who maintained a healthy lifestyle. It is not me though. He exercises regularly, doesn't smoke or drink alcohol, and keeps his weight in a normal range. Recently, however, he experienced generalized muscle weakness and headaches. He attributed the headache to the stress of facing students with poor grades. Pain medication did not help. His wife was very concerned and made an appointment for him to see his primary care physician. On physical examination, his blood pressure was significantly elevated at 180 and 100 milligram Hg. And laboratory test results show that arterial blood pH was 7.5, PCO2 48 milligram Hg, HCO3 36. Venous blood sodium was 149, potassium 2.0, plasma lane activity decreased, serum aldosterone increased, urine sodium excretion decreased, potassium excretion elevated. The CT scan confirmed that the presence of a single adenoma on the left adrenal gland. Then he was diagnosed as the hyperaldosteronism. Then questions. I have prepared 5 questions. So I will pick up some student from which I will close my eye and pick up which group. Okay, A1. I'll close my eye, select one. Okay. Najiwa Belkis, Shahab, could you answer the question 1? Could you unmute and
Yes, Professor.
yes, please.
Is his blood pressure within the normal range? No, because his blood pressure is very high. His blood pressure is 180 per 100, which the normal pressure is between 90 per 60 to 120 per 80.
Yes.
Thank you, Prof.
So why his blood pressure was elevated? Mechanism. I want to know the mechanism.
His blood pressure increased significantly to 100 per 180 per 100, exceeding normal. The cause of the professor elevated blood pressure was the presence of a single adenoma on the left adrenal gland that caused an overproduction of aldotestosterone. The increase in serum aldotestosterone levels would stimulate an increase in the number of sodium channels open in the principal cells of the luminal membrane of the renal cortex of the ductus collectus. As a result, in the increased sodium reabsorption increase, this leads to increasing blood pressure.
Why? Why increase in sodium channel increase the blood pressure? There is some big gap between the sodium increase in sodium channel and the increased blood pressure. There is a big gap between them.
The increase in sodium reabsorption leads to several mechanisms like increased extracellular fluid volume, osmotic effect.
Why? Its action is in kidney, right?
Yes.
Collecting duct. So the sodium channel is increased in collecting duct. So absorption of sodium from a renal tubule is increased, right?
Yes.
Then what's happened next? Up to here, you're correct, but there's still some gap. You don't know? Okay, I can move to the other person, to the other group, maybe.
Thank you, Prof.
Okay, so good challenge. Okay, I'm gonna move to group A2. Okay, okay. Karina, Tadikadewi Herianzo.
Yes, Prof.
Karina, yes. So what is the mechanism causing the high blood pressure by expressing the
From
sodium
what we
channel?
discussed,
Yes,
I think the high blood sodium concentration and
yep.
low blood potassium concentration work to increase the blood pressure. Then high sodium
Mm,
levels in blood causes water retention, which in turn increase the pressure exerted by the blood against the blood vessel walls. Aldosterone
mm,
regulates sodium,
mm,
keeping it in the blood, and potassium, decreasing the concentration of potassium in the blood by absorption. The high value of serum aldosterone may be the main cause of the hypertension and low
yes.
blood potassium levels experienced by the physiology professor.
Okay, again, what is the site of action of aldosterone? This is not the blood vessel. Okay. Aldosterone act at which organ? The previous students said that aldosterone acts at collecting duct, right? Not in blood vessel. So aldosterone act at collecting duct or distal tubule and increase sodium uptake. Up to here, this is correct. Then increase in sodium uptake from collecting duct will cause what? This is the question. You don't have any idea?
Sorry, Prof. I don't have
Okay.
any idea.
Okay, so I'm gonna move to group A3. This is very important. Okay. Nasi wa?
Yes, Prof.
Yes. Do you have any idea?
I'm sorry, but could you repeat the question? I don't really get what the question is about. I'm sorry, Prof.
Okay, you can get a question, you can get an answer.
I don't think I get the idea of the question.
Okay, so anyone can answer the question through chat. This is very important. Okay, this is the basic mechanism of aldosterone causing hypertension. So no one can get the correct answer so far. Anyone can tell me? This is very important. No one? This is problem. This is very important. Professor Arifan, I believe the student has finished taking a course of circulatory physiology and renal physiology, right? Okay.
Okay. Okay. Yeah, because the program, the module is not finished yet.
Oh, summary. Okay. Okay. I'll explain. Okay. I'll explain. I'll explain. Okay. In collecting duct, here, and this is cortex. Oh, sorry. Cortex. And here medulla. And aldosterone can aldosterone can absorb sodium, right? Up to here, everybody understand sodium. So what's going to happen inside of the renal tube? It can cause hyperosmotic or hyperosmotic. It's become hypotonic, right? You understand? Right? So increased sodium uptake can cause renal tube hypotonic. Then it's moved to medulla. Interstitial place or medulla is generally hypertonic, right? Everybody knows? Okay, medulla is, compared to cortex, interstitial space of the medulla is hypertonic. So due to increased absorption of sodium, renal tube become much more hypotonic. Then if moves through immediate medulla, more water is absorbed in here. More water is absorbed in here. Okay, so reabsorption of water is increased by the increased secretion of aldosterone. So the fluid volume in body become very high, causing hypertension. This is a mechanism, okay? So the important point is the site of action is collecting duct and distal tubule to increase the absorption of sodium. Then inside the renal tube become hypotonic. So the increased osmotic gradient can induce more water to absorb. Okay? Okay. All right. So this is a little bit difficult, but this is very important things to know. Next, based on PCO2 and HCO3 levels, determine whether he has metabolic alkalosis or respiratory alkalosis. Explain the reason why you determined so. Okay, I'm going to move to the next group, A4. Violeta, Windy.
Yes, Prof.
Yeah.
Our group answer is metabolic alkalosis. When
Okay.
respiratory alkalosis occurs, the PCO2 and the HCO3 concentration is decreased. But when the metabolic alkalosis occurs, they increase. So we can see from the laboratory test result that the patients dose increase. So we can conclude that the patient has metabolic alkalosis.
Yes, okay, correct. So metabolic alkalosis is called based on the pH level and HCO3 level, which is very higher. It's higher than the reference value. So we can conclude metabolic alkalosis is induced. However, by looking at PCO2, which is a little bit higher than reference value, why PCO2 is elevated? Do you have any reason why PCO2 is elevated? Why PCO2 is elevated? Can you guess?
Sorry, Prof. I don't have the idea yet.
You don't have idea. Okay. Okay, group A5. Akila, Ditsky, Putri.
Yes, sir.
Do you have any idea why PCO2 is elevated?
Based on the chemical equilibrium on the blood.
Mm-hmm. What's
Uh,
gonna happen? Yeah.
so alkalosis condition is excessive blood alkalinity based on the equilibrium. It
Mhm.
happens when the carbon dioxide decreases and by bicarbonate ion increases. The decreases of carbon dioxide or the loss of the carbon dioxide made the partial pressure of carbon dioxide uh, the what happened is the metabolic alcoholysis, right? So it doesn't the loss of carbon dioxide is not happening. That means the partial pressure of carbon dioxide is higher than the normal range.
But if the carbon dioxide level becomes high, it may become acidosis, right? Respiratory acidosis, right? But why alkalic? Why pH alkalic even though PCO2 is very high? PCO2 is higher.
Because the carbonate ion is high too.
Yes.
So what happened is alkalosis.
Yes, right. But why? My question: why PCO2 is high? If the alkalosis, PCO2 should be low, right? If alkalosis, PCO2 is low, but we saw the higher PCO2 here.
Because the hyperventilation is not happening.
What?
There is no hyperventilation.
Why hyperventilation is happening?
It doesn't happen in the case.
Why?
Hyperventilation.
Okay. Why you think about hyperventilation?
Because there is no the patient doesn't complain about shortness of breath.
No. Thinking about acid-base balance. Okay, I'll explain again. Okay, you have to think about the equation. You have to think, okay, I'll work out everything. Well, how can I? Sorry. Just a second. How can I? Okay, so you have to think about the equation. CO2 plus H2O can move to H plus HCO3 minus, right? Everybody knows this equation, right? Okay, so they caused this metabolic alkalosis. Probably the main cause is the decrease in metabolic velocity could be caused by the decrease in, oh, sorry. Decrease in, doesn't work. Come on. I don't know why. Decrease in proton secretion, right? So this decrease can cause shifting of this CO2 to here, HCO3, right? To induce the increase in proton to maintain the equation. Everybody understand what I'm talking about? Everybody understand? Okay, so aldosterone can increase the circulation of the proton, right? Which may cause alkalosis. So to increase the proton, CO2, this equation can move to here, causing the increase HCO3, right? That's why we see the increase HCO3. However, CO2 is actually elevated. Why CO2 is elevated is they want to have a more supply of CO2. They want to have a more supply to CO2 to the tissue, or they inhibit inhibition of respiration to increase the increase in CO2 in blood. So this is what we call compensation mechanism. Have you heard about the compensation mechanism? You have heard? Not yet? You haven't not learned yet? So this is commonly happen, okay? So the inhibition of respiration can induce an increased CO2, causing shift from here to here to induce the increase in proton to normalize the pH level in our body. Understand? Everybody understand? Any questions? Could you raise your hand if you do not understand what I'm talking about? Could you raise your hand? I'll explain more. Everybody can understand? Using the hands up sign. Could you raise your hand if you don't understand? It does not seem no one is raising hand. Okay, one. Only one?
Sorry, Professor.
Yes?
I want to ask.
Yes.
Basically, what you're explaining is the body tries to elevate the amount of carbon dioxide to to balance with the HCO3.
Well, the main purpose to change equation is to increase the proton. Okay? Because you want to keep the pH under normal condition. Yes, understand? Up to here?
Okay. Yeah.
Then, as a result of shifting from left to right, HCO3 is also increased. This is what we saw in the arterial gas. But CO2 could be decreased, right, under such condition by shifting from left to right. However, if there is some compensation mechanism in your body to inhibit respiration, CO2 can be increased, as a result of compensation. So please study again the compensation mechanism. Then you can understand. So acid-base balance is a bit difficult to understand. Okay. So this is okay. So this is a bit difficult. Okay. So I already explained the mechanism causing pH elevation, right? I already explained. So aldosterone can increase the secretion of proton into renal tubule in the distal into the distal tubule, right? So increase in secretion of proton caused by aldosterone can induce the increase in pH. Okay. Okay, so the question number 4, why was hypokalemia caused with increased sodium level? Why hypokalemia is caused? Group A6. Okay, A6. Answer. Do you understand? Do you have any idea? Answer. Shalom.
Yes, sir.
Why hypokalemia is caused?
Hypokalemia is caused by increased sodium levels due to excessive aldosterone, which can lead to excessive potassium excretion in the urine.
Yeah.
The expected clinical symptoms of hypokalemia include muscle weakness, fatigue, cardiac arrhythmias, and disorders of the nervous system.
Okay, very good. Okay, hypokalemia is caused by the elevated aldosterone, because aldosterone not only secrete proton, but also it secretes potassium into the renal tubule, right? So muscle become weak, cardiac arrest can be induced. Okay, does anyone knows why hypokalemia cause a cardiac muscle weakness? What is the role of potassium on muscle membrane? What is the role of potassium on neuronal membrane? Anyone knows the role of potassium on muscle membrane or neuronal membrane? What is the role of potassium? Can anyone answer through chat? You can understand the symptom. You can tell me the symptom, but you have to know the mechanism causing such kind of symptoms. Otherwise, you really cannot know the etiology of the disease. What is the role of potassium on neuronal membrane or muscle membrane? Anyone can tell me? Yeah, balance of sodium concentration, but this is one role, but this is not the main role causing a main cause to cause the muscle weakness. Any other idea? What is the role of potassium on cellular membrane? Yes, conduct the muscle contraction. Yes, that's true. But this is, yep, nice idea. Yes. It can cause hyperpolarization. This is correct. Okay, so potassium can stabilize resting membrane potential. Okay. Okay. So calcium is responsible of controlling the resting membrane potential. If the calcium level is normal, resting potential is stable. But the lower calcium, resting potential become mainly hyperpolarization, but actually it become really, really unstable. So it can cause a weakness of the muscle. On the other hand, high potassium level can increase the resting membrane potential to higher. Then the threshold and resting membrane potential gap is very, very small. Then it can contract so quickly if the potassium become very high. Okay, so this is a clinical symptom caused by hypokalemia. Okay, finally, why plasma renin activity decrease? This is an easy one. Okay, group A7, CT, Fatina, sorry, CT. Could you please tell me the reason why plasma renin activity decreased? CT, you hear me?
Okay, sir, from
Yes, please.
so we conclude in patients with low renin essential hypertension, renin levels are reduced, leading to unique features such as salt sensitivity and a different response to lifestyle modifications compared to other hypertensive patients. The cause of low renin hypertension include conditions like Cone syndromes, Liddle syndromes, and apparent mineralocorticoid excess. And
Yes.
lower levels also could be from primary aldosteronism, steroid therapy that causes you to retain salt, and salt-sensitive hypertension.
Yes, you explained about the Cone syndrome, but what I want to know is the mechanism why renin is decreased. This is quite simple. My question is quite simple. Why renin is decreased? Why? Could you tell me why renin is decreased?
Sorry, sir, I have no idea about that. But I think renin suppression is due to aldosterone-dependent sodium irritation and mild extracellular volume expansion.
Well, this could be the reason, but it's more simple. Okay, it's kind of a negative feedback. Okay. Not only like a pituitary or hypothalamus has a negative feedback, but also many endocrine systems have negative feedback. So renin activity decrease due to the increased level of aldosterone, which can inhibit the renin activity. It's quite simple. Okay, this is the kind of mechanism of negative feedback. Okay, all right. So actually, acid-base balance is very difficult to understand, but you know, we as a clinician, we spend a very long time to control acid-base balance of the patient, okay, by controlling the respiration or by giving the IV. So acid control, but acid-base balance is one of the key issues to treat a patient, okay? So you have to know the terminology compensation, which is very important, okay? So, and the equation that I wrote, acid-base balance, is one of the key to understand, okay? So everybody knows Henderson-Hasselbalch equation, right? This is kind of very important feature to learn. Okay, I'm gonna move on to this. Okay, So this is kind of basic thing. So pituitary can secrete ACTH, and adrenal cortex can secrete cortisol, and only cortisol is involved in feedback, as I told you. So if cortisol is gone, testosterone is increased. However, important thing is aldosterone is not regulated by ACTH. Okay, aldosterone is regulated by angiotensin 2 directly. Okay, the angiotensin 2 is converted from angiotensin 1 in the lung through angiotensin converting enzyme. Then renin is secreted in granule cell of the kidney, which convert angiotensinogen to angiotensin 1. And there is 3 important factors to regulate renin. One is afferent arterial pressure decrease, or distal tube sodium chloride decrease, or sympathetic nerve activation. These 3 factors can stimulate renin secretion. Okay? So finally, important thing is the site or aldosterone action, particularly these 2, distal converted tubule and collecting duct. So aldosterone can increase the expression of factors shown in red, particularly proton ATPase, which pump out the proton into the renal tubule. So high expression aldosterone can increase the proton secretion, causing alkalosis. In collecting the chief cell, on the other hand, aldosterone can induce the secretion of potassium into tubular side, into the renal tubule. So hypersecretion of aldosterone can decrease the potassium in our body. On the other hand, sodium absorption is increased, so sometimes it causes high sodium in your body. Okay? Okay, almost the time is up. Acid-base balance could be a little bit difficult issue to understand, but please study hard to understand acid-base balance, which is the kind of key issue to be a clinician. Okay, any questions? The time is up, but if you have any questions, I will accept it. Do you have any question? If not, I'll tell you my email address, so you can send me. And actually, we have Gunma University will have a summer course in August, and you have there. I believe that there must be some selection inside Norwegian University, but we invite all of you to join our summer course. Sometimes virtually, and we may have some scholarship, although it really depends on the budget of the university. So you may have opportunity to virtually or really visit Gunma. So please ask more in detail from Professor Irfan and people in the Norwegian universities, and I can see you again during the summer course. Otherwise, usually I visit Norwegian University like every other year or something like that. So actually I visited last year. So this year, next year, I'm pretty sure that I will visit Sriwijaya University again, so we may have opportunity to see you face to face. Okay, any question or comment? Okay, if not, thank you very much for attending. Yeah, thank you very much for attending. So we will close the session.